Actually, this study had ambitious biomarker plan initially, especially with tissue. We planned, on tissue, on treatment biopsies and to evaluate biomarker changes before and after. However, unfortunately, the study was conducted during COVID, so all these research biopsies were aborted per hospital's policy. However, we still had significant blood or peripheral blood work that we reported in our Nature Communication paper. So initially, we studied the effect of different immune cells population on response. We observed that myeloid-derived suppressor cells, MDSCs, which are known to have immune suppressory properties, these MDSCs were inversely associated with response, showing that the highest level in patient with progressive disease and lowest level in a patient who had response, partial response. We also observed that patients responding to treatment had the highest expressing interferon and TNF-alpha in CD8 T cells at baseline, which was not necessarily too surprising to us. We did study other transcription factors, including FOXP3 expression in CD4 T cells, which is expressed. FOXP3 is associated with regulatory T cells, which are known to have immune suppression properties. And these transcription factors were significantly lower in patients who had partial response. And other transcription factor, including the ROR gamma T, which is an important transcription factor for peripheral immune cells differentiation. And we observed that this was significantly higher in patients who had partial response compared to the progressive disease. So of note, CD8 T cells expressing ROR gamma T, also called TC17 cells, have been shown previously to promote inflammation and contribute to defense against infections and participate in autoimmunity. So it was interesting to see that in our peripheral blood at baseline, the ROR gamma T was significantly higher in patients who had partial response. Since our study is utilizing hypomethylating agents, so it was a normal, next step to study the methylation at line 1, which is it stands for long interspersed nuclear elements. It's a marker for methylation. So measurement of line 1 in 25 samples in both at cycle 1, day 1 at baseline, and cycle 2, day 8, showed a decrease in methylation, which was observed in 22 out of 25 samples, accounting for about 88% of our patients, which was statistically significant. And this suggests the overall efficacy of guadecitabine as hypomethylating agents. We also studied the chemokine expression, CXCL9, 10, and 11, based on our preclinical data, as we discussed earlier. So we measured them at baseline and at cycle 2, day 8. We observed increase in CXCL9, 10, and 11. We noticed them; they were significantly induced by treatment, and this increase was mainly observed in patients who had response per the RECIST criteria. There was also a trend towards improvement in PFS with the increase of these chemokines. Nevertheless, this observation needs to be further validated in future studies. needless to say that we are in the kidney cancer field. We are really hungry for a new mechanism of actions, if you will. For years and years, we got stumbled on TKIs and tyrosine kinase inhibitor, VEGF inhibitors, and checkpoint inhibitors. Majority of our drugs we use currently in the clinic tackle those pathways. We have now HIF2 alpha inhibitor. So really beyond that, majority of our drugs currently are still in investigational phase. So really having a new mechanism or new pathway to tackle certainly is of interest for the community, for the kidney cancer community. Now, this trial was a phase 1/2 early phase clinical trial, small sample of patients. Yes, it did not meet the primary endpoint of improving overall response rate. However, the progression-free survival signal and the stability of the disease for a prolonged period of time in this patient population is intriguing to study it further. Maybe I would propose a randomized phase 2 trial, or mainly focus on the patients who progress on a prior lines of therapy. Even though we did not have that signal in the checkpoint inhibitor failures patients, it was rather in the checkpoint inhibitor naive patients. So I would focus on that patient population who did not see checkpoint inhibitor and maybe randomize it against the standard of care. Obviously, the logistics of this clinical trial might not be as attractive because in the design you saw that Guadecitabine was given like 5 days in a row, as opposed to the current standard of care. When you are talking about TKI, they are like oral pills that are being taken on a daily basis at home. So this might be a challenging situation from a logistics standpoint. However, I wouldn't say this should be the end of era of hypomethylating agents in kidney cancer. It should be actually studied maybe with a different design. Do we really need 5 days in a row? Maybe not. So hypomethylating agents have been utilized in hematologic malignancies. Still, they are making their ways into solid tumors, but I think it's certainly worth further investigating, especially in our kidney cancer population.